Hey everyone, and welcome to our webinar. I'm Kate, and today we are talking about interoperability. We're going to talk about how implementing interoperability in your pediatric practice might be easier than you expect, and how it is shaping the future of care delivery. We've got a great team here to guide us. Dr. Peter Schoch, he is a doctor who's been on both sides of healthcare, treating patients and leading big health systems, and Therasa Bell, the tech whiz who co-founded Kno2, an organization whose mission is to make sharing patient information seamless and easy. Together, we're going to show you how streamlined communication can actually make your workday less stressful. We're talking smoother workflows, happier staff, and better care for your patients. Don't be shy. If you have any questions, pop them in the questions chat. We will get to those after our discussion today. But before we get started talking with our guests, we would like to kick things off with a poll question for all of you in the audience to answer. That's going to come up on the screen, and you're going to be able to answer those questions directly within the survey itself. So go ahead and complete that poll now. Our first question is, how do you share patient records today? And you can select all that apply. Okay, Therasa, Dr. Schoch, love to get your thoughts on these results.
I certainly reflect the hand-delivered mail and phone. That was a large part of my practice, and maybe that's just aging me, but it is, and fax, obviously. I think there was a constant whirring of fax machines in my office. I think we had 4 or 5 fax machines for a practice of 5 physicians and 1 physician assistant, and I don't think they ever stopped moving forward. Therasa, I'm sure fax is close to your heart as well.
Oh, well, I was looking at these poll, the answers that people could select, and I was like, the only thing missing here is like carrier pigeon. So, what are we missing from the list? And unfortunately, I don't know if I'm depressed about this or if it's exciting, because I think we have a lot of technology to offer here, but unfortunately these answers haven't changed for quite some time, and I think that's going to be a big part of the discussion today. But literally the only thing missing is carrier pigeon. So that would be the results I would have back here.
Awesome, thank you for that feedback. So now that we have a sense of how you are all sharing your patient records today, we're going to move on to a second poll question. Okay, so love to get your thoughts, Therasa, Dr. Schoch. I'm really curious to hear your thoughts on this.
Again, I look at the list, and Dr. Schoch, you probably know this more intimately than I would, but is there any workflows left in the in the clinic that says that not pretty much everything is impacted by the exchange of information? And again, makes me excited for the conversation today. But love to know what would sit in that other bucket. If people want to put that into the chat, would love to know what people are seeing there, and what we haven't covered. But I think this kind of covers everything. Love to get your input, Dr. Schoch.
Yeah, no, I agree. And it doesn't surprise me that they're all pretty close, meaning that they're all significant workflows that we deal with on a daily basis. So yeah, it doesn't surprise me. I also am interested in the other bucket, and also great setup, both the previous poll question and this question, for our discussion today, because I think we have a lot to talk about, and I think there's a lot to offer in the realm of communication, healthcare communication, that will impact how folks practice.
Yeah, I would entreat people for the other bucket, if you don't mind taking a few seconds and putting those into the chat. Would love to know what other workflows that we should be considering as part of our discussion, if people have a minute to do that.
Therasa, did you, would we also like them to put in the chat what one information exchange wish would be? If they could have just one wish, what would it be?
Yeah, that would be great. I think, from my perspective, as a person that's dedicated literally my entire career to seeing health information exchange happen at scale for our provider communities, would love to understand it from the perspective of the provider. And what would they love to see if they could wave the magic interoperability wand, if there is one. Somebody needs to give it to me, because I've been doing this for a long time. But if somebody just could wave that wand, what would it be for a pediatric office to understand what it looks like?
Hey, can I put forward my wish, Therasa, just in a second? Can
No,
we stop
this
talking
wasn't
about it?
open. This was
I wish
open.
we'd stop talking about interoperability. And
Yeah.
I'm saying that somewhat tongue in cheek and provocatively because at the end of the day, I don't know any of my colleagues who went out and said, hey, I'd like to, how cheap is your interoperability? I'd like to go out and buy one interoperability, please, because I think it's going to solve all my problems. I don't think anybody looks at it that way. Partly because I think we've created some complexity around interoperability and I hope to demystify that in the conversation that we have today as well.
Well, again, we didn't open that up to you because as I work through now my identity crisis, because I have nothing left to talk about. That is, yeah, I totally get it. I say that all the time. The day that I don't show up on a webinar or I don't go to a trade show and interoperability is not the theme of the day, I know I've done my job and that I've done my job in solving the problem for the broader provider community.
Well, it's interesting to see that we did not get anyone to kind of write in the chat their one wish, and probably to your point, Dr. Schoch, because it's multiple things, right? And from that standpoint, we just really appreciate everybody's feedback. But at the end of the day, interoperability is a buzzword. It's got multiple meanings and contexts. We know this. So Dr. Schoch, I was hoping that maybe you could share an explanation, your viewpoint of interoperability and its context for pediatric practices.
Yeah, I appreciate that. Ask the dumb guy first, right? The non-technical provider. And Therasa and I go back and forth on this a lot, and I think there's a lot of alignment and agreement around it. And I think depending upon who you're talking to, perhaps changes the dialogues, obviously, in the words you use. But very much like healthcare has its own vernacular and its own language that patients have a hard time understanding, and we have to serve as translators for. I hope I can serve as a translator for the technical component into the impact for interoperability for providers. So when I think about interoperability, I really think of it as two simple components: data movement and data magic. Data movement requires that you be connected to a network and have pipes that allow the exchange of information from one location to another. Data magic is what happens after you receive that information, sometimes as it transits across the network, and sometimes what happens on the end before it's sent to you. And what that is the idea of what data is sent. Can we deduplicate? Can we scrub? Can we enhance? Can we consolidate information that you receive? And then once you receive it, how does it get to the right person, the right place, the right time in your workflow such that you can actually use the information to impact workflows and critical decision making, which we do thousands of times a day, some clinical, some non-clinical, but that information is critical in that. So that data movement, the connectivity piece, and data magic, the meaningful communication in terms of what data we get, where it's placed, how we use it, how we process it. And I think there's a lot to discuss in those two things, but that's my simple kind of explanation for interoperability that helps me understand it, because I think then it allows us to have a conversation, not so much about the different standards of communication like HL7, FHIR, and all those things we like to talk about and need to talk about on the technical side. For me as a provider, I just need to know, am I connected? Where does the information come and what information can I get? Because that's the impact that drives what I do in my office. So Therasa, I don't know if you have, I know we go back and forth on this a lot, and I know you got into this thinking about the impact of information sharing on providers and freeing them up to provide better care. So I'd love to get your cents on it as well.
Yeah, I think in the definition of interoperability in itself, to me, needs to be without thought. So if we look at the first set of polling question that came out, is what are all the different ways in which you share information today? And it was a strong result for at least 3 of them. Actually, all of them had a strong participation, but all of them require effort and thought. And that is the antithesis to what interoperability for healthcare is supposed to be solving, where a provider doesn't have to think about it, to use Dr. Schoch's word, about what's happening behind the scenes. Data is moving, and it's moving from the hospital. And we did have somebody respond back here with, they would love to get the baby name, and I'm going to use that as the example, is that when a baby is born in the hospital, the ability of that information to come from the hospital into the selected pediatrician and have that information just flow into the right parts of the chart when I have 2 or more electronic health records involved, right? That there shouldn't have to be this consideration by the provider on what they what they need to do to go get the information. That should just happen. So when we get to the point where the movement of data, because of the magic we apply to it, is without thought and without effort from the provider, and we're serving up what they need in that moment, again, I'll know that we've done our job. And that is what the spirit of interoperability is supposed to accomplish in healthcare. And as you can imagine, that's very complex and it's very hard because there is a lot of healthcare information. It is massive. It's exploding on a yearly basis, the amount of information available to providers. But as Dr. Schoch has always taught me, it's not the amount of information that's important to the provider, it's the right information showing up in the right place in my electronic health record. And again, that's when we know collectively, when I say we, it's a Kno2 office practicum thing, that we have done our job, because we'll serve it up to OP and then they do the magic and they'll extract what's needed for that provider to be able to look at the record appropriately.
Yeah, a couple of things on it too, just as you're saying that, it stimulates a couple of thoughts that we talk about a lot of times. There's this old concept, and I believe it's a biblical concept. I don't know exactly where I first heard it, but interoperability is kind of like the wind in my mind. I don't want to worry. I should never see interoperability. I should never see the wind. I can always see the effects of the wind. I can see it moving the leaves of the trees, blowing the grass, the ripples on the water, those kind of things. That to me is when interoperability is working. And to Trace's point, when I have the data, it's in my workflow and it's the data I need to make decisions. And I think that's a big deal. I also think that this concept of interoperability, we talk about it as if it's a new concept. And I would imagine that every provider on the phone has been interoperable since the day they were born into their provider suit, right? Meaning that all those ways that we exchange health information, that's all interoperability, right? But it's not scalable, and it requires significant effort to go get that information and bring it into the right locale. What we're talking about is a next generation of interoperability, tech-enabled, that allows us to do it in a seamless, effortless fashion and get it right where it needs to be, saving us as providers time is money as a provider, and allowing us to decrease our administrative burden and spend more time with patients, which is really what we got into this in the first place for. So much more we can say on that, but I think that kind of encompasses what I think about of interoperability from a provider perspective.
Yeah, I think there's an interesting comment that came into chat. Again, I'm trying to pull the audience in here, because until interoperability is made real to the daily challenges that our providers face, it's not meaningful. And so if we look at the chat, the comment here is that the biggest hurdle is intake forms and ASQs. And Dr. Schoch, you may know what that means. I don't know what that means. That's not a technical acronym I'm familiar with. But that patients fill out on form or from the website, getting them into the electronic health record. My instinct says that in those intake forms are likely asking medical history. They're asking information from maybe a previous provider. And all of that information, one, can also be collected through connection with other clinical offices. So let's say it's the health system or another pediatrician that patient has had. Maybe they had a recent event, healthcare event, that went outside the pediatric office and they want to get that information back into their EHR. All of that is made available today through the relationship that OP and Kno2 have and the integration that we've done to be able to collect that information, again, without effort, and get it into the record within Office Practicum. That is the essence of interoperability, is taking how we share information today in a manual way and moving it to an electronic, streamlined, automated fashion. And I think that's a perfect example of one that can be solved quickly.
And Therasa, just building on that too, I think I want to extend that to just information about new patients. One of the biggest things, if I'm seeing a new patient in my practice, how do I get as much information about that patient as I can possibly get before they come see me that's relevant to the visit, right? And how do I do that in as easy a way as possible, meaning not that I have to call, fax, download, sift through records, but how do I get them right into my electronic health record so that I can review them with the patient when they're there. The other thing I think that's important about the patient intake forms that I don't think we realize enough, not only is it a provider experience issue, but it's also a patient experience issue. And I'm sure whoever wrote that sees that as well, meaning that there aren't too many places where I want people to know me. But my doctor, I kind of want them to know me, and I kind of want to feel seen and known by them. So rather than filling a form out every time, it'd be nice if that information were passed forward in an electronic way that allowed them to have that information and start with a verification of that information as opposed to having to gather that information each time, each doctor, et cetera, et cetera. And I think interoperability can help solve some of that problem. It's a major benefit in the relationship building with patients, for a patient to feel seen and feel known by their provider.
And I'll relate that to not a pediatric office, but actually the other way with my father who has Parkinson's. And he here roughly a year ago, had an event where he sees a neurologist every 3 months for his Parkinson's review and his update. And he had an event where he fell and broke his hip and had some pretty significant rehab and everything that goes around that for a Parkinson's, 80-year-old Parkinson's patient. And I happened to be home with him and take him to his routine neurologist appointment and brought him in. Clearly, they had no idea, even though, by the way, they were part of the same health system, his neurologist had no idea that he had this event about 2 months earlier that he was now recovering from, where they handed him like an 8-page intake packet for him to complete, by the way, and he was a Parkinson's patient, that had all this information on it that if they would have known everything that he had gone through, that was absolutely impacting between the medications, the rehab, and everything was absolutely impacting his Parkinson's prognosis. And if they would have known, the experience would have been so much better for the provider. By the way, she was fantastic. She's a fantastic neurologist, but she was on her heels the entire time trying to collect the information. And for my father, that experience would have been so much warmer if they would have had said, hey, we understand that you had a recent event. Let's kind of level set and get you to a new normal. Of course, I'm speaking my technology speak, not my provider speak. But I relate that to really that fits into any care setting, and what was put into chat is that warm experience, that warm handoff for both the patient and that provider is critically important, and one of the key elements that interoperability serves in creating that cohesion in the experience.
Therasa, and I know Kate wants to move on, but Therasa, just on that point too, I think that's more relatable to pediatrics than you may think it is. And the reason I say that is because my pediatric colleagues deal with patients in many cases who cannot give them the history, and they have to get the history from the parent, and the parent may not be able to give the history in the way that they need to get the history. So that idea that, hey, not only is there information out there that I need to get, but I may not be able to get the information that I need from the individual in front of me for whatever reason, I think is critical, and interoperability helps with that, or the communication helps with that if we can streamline it. So sorry, Kate, I know that we went long on that answer, but
No. That's great. That's great. I appreciate both of your perspectives. I really love that you touched on the patient experience, but there's also the practice experience. I mean, both sides of it are really struggling if they don't have I think as you put it, the new generation of interoperability, which is here now. And so one of the things that we want to do is send out another poll question, final poll question for our audience. And it kind of ties right into what we're talking about here. What's your biggest hurdle in adopting interoperability? So we're going to give you a few moments to go ahead and submit your answers. Okay, so Therasa and Dr. Schoch, does this align with what you're seeing in your work?
It does. And actually, there's one surprising thing to me, and I'll say it, is that often I'll hear privacy concerns. That there is concerns, and we actually heard it at the last Office Practicum user conference, that there was some concerns about privacy. Is it being handled with these national networks today through a fax machine or through the mail? The one benefit, if you want to say it, that people feel is a sense of control, because they can control what goes out and they can control what happens. So I'm surprised not to see that at 0%. I am not surprised to see that other providers or organizations in the network may not be connected. I continually say that the biggest challenge we have in interoperability is not the technology itself, it's the awareness. And the awareness of who else can do it, how can they do it, does my EHR talk to that EHR, and how do I go about getting awareness of who can connect to me and who cannot, especially since EHRs, even simple things like naming like direct messaging or care quality, which we'll get into a little bit. Those are technologies and names of things that don't persist into the everyday world of the provider. And they certainly don't show up that way in the actual product. So when you call maybe another provider that's on a different EHR, they will call it something completely different. And it's like two ships passing in the night saying, hey, do you use direct messaging? And they're like, I have no idea what you're talking about. But there are ways to get around that. And that is one of the biggest, I'll say at a national level, that I'm involved in, is working with the electronic health record vendors and with the groups to get around this awareness challenge, because it is absolutely the biggest hurdle to interoperability. I always say, imagine, I don't remember these days, maybe some folks do, but when the first kind of fax machines were going around, or when email started, it was an awareness problem, right? You didn't have the fax number of folks. You didn't have
or cell phones, right, Theresa? I mean, you know, you can get a cell phone, but if none of your friends were on it, it didn't do you a whole lot of good.
Yeah, exactly.
Right?
And so this challenge of awareness is a big deal, and it's absolutely spot on. So I'm not surprised by that one at all. And Dr. Schoch, I'll hand it to you.
Yeah, no, I was a little surprised by that one, to be honest with you, because what that tells me is people are looking. If I'm interpreting that right, what it means is people are actually looking to get connected, but they're not seeing the people they do business with being connected, or aren't able to have those conversations. So what surprises me is maybe they're further down the road than I thought they were, in terms of getting themselves connected, which is a very good thing. The privacy concerns one did surprise me a little bit, because that tends to come up frequently, especially in the last 6 months. We've tended to hear that more, not necessarily from individual providers, but from industry people. So maybe that's just having our finger on the pulse of providers versus industry. The one about need to change workflows and need to educate myself and staff to use tools correctly, and I don't have time to do it right now. It'd be interesting to understand the mindset of those who answered, chose one over the other, or chose two of the three, because they all feel kind of interrelated to me. And I think one of the things that I was always challenged with as a provider, and then as a health system executive leading transformational change within provider practices, pediatrics, adult medicine, and so forth, was time is money. I'm just going to be honest about that. And time is money. One big principle I don't think a lot of people understand when they go into a physician's office and ask us to change our process. Number two, we as physicians build habits and patterns of work that allow us to feel that we are complete and not missing things and not making mistakes. We do that even down to where we see information. We have a specific way in which we read chest x-rays to make sure that we're not missing any part of the chest x-ray that may lead us to miss an abnormality. We have a familiarity with where we look for lab results in an EHR or in our paper charts years ago, et cetera. When those things change because we're changing our workflow, it is far more disruptive than a non-provider would understand. And I think it is a significant barrier, whether it's the workflow, whether it's education about the use of a new tool and where things are placed. So those things don't surprise me at all. And I think there's got to be some ways that we can help recognize those things, deal with them right up front, to eliminate some of the change management that needs to take place in that regard. And then just, again, recognizing that time is money. If I have to slow down for 2 weeks to learn a new workflow, I actually see fewer patients, or it makes for longer days. The patients feel it, I feel it, and if I don't make for longer days, then it ends up impacting revenue stream. So those are just realities that I think we have to address honestly and upfront in order to really overcome some of these things. Because on the other side of it, once the process has changed, once that information is freely flowing, oh my heavens, it unlocks so much. It unlocks efficiency that actually adds to revenue and reduces expense, adds to provider satisfaction, adds to patient satisfaction. And I think that's an incredibly important point. There is a rough patch, but on the other side of that rough patch is green fields and a wonderful pasture to rest in, that I think really drives your business and unlocks a lot of potential in the business.
I don't know if you're following chat, but you were somewhat in line with the most recent comment that came in, Dr. Schoch, and I'll just read it out loud to the audience, is that interoperability is great for patient continuity, but the providers and staff do not have the time to read all the information. They're overwhelmed with the fire hose of information coming at them all day. If payers recognize this and accounted for the time it takes with reimbursement, it would certainly be more successful. I thought that was a very, astute thought process and interesting perspective on reimbursing for the data. I'd love to get your input on it. I obviously can't comment on it as a provider. I can certainly comment on it from a technology perspective and some of the things that we're overcoming right now with that. It's very real.
You've heard me say from the highest mountaintop in the loudest voice, stop giving me more data. Give me information. I believe that there's this life cycle of data, if you will. Data in and of itself does me no good. Data in the context of something, a patient record, et cetera, is information, and that has a little more value. Information that actually is given to me at the right time in the context of the decision I'm making and is relevant to that decision, that's knowledge, and that's what I really seek. And then the more that I have that knowledge over time impacting my decisions, it becomes wisdom, meaning knowledge just kind of baked in that regard. So there's this life cycle of data. I don't want more data. And this is where I do think interoperability to some degree fails out of the gate historically. And that is, we've opened the floodgates for data, but we haven't really solved the problem of what data is relevant for what provider and what circumstance. And so we tend to deliver a lot of data to the point in the chat that they have to filter through. And we'd love to get there. And I think, Therasa, you can talk to this from a technical perspective. There are opportunities as we go through the next several years in interoperability with the rise of AI and already the data enrichment that we put onto the data coming through the network, which deduplicates, uplifts the data, consolidates data, et cetera. And then you put an AI filter on top of that that's relevant to what you're particularly talking about. There's a real opportunity here to distill down data into knowledge that's delivered to providers. And so it's not just more data, it's actually relevant data. And we've got a number of partners that are doing that work now in different settings. And it's very exciting work, because I do think it really begins to make good on the promise of interoperability, free-flowing information, but not a flood of information that you drown in, free-flowing information that's relevant to you to do the work you need to do. So just my thoughts on that. You made a comment about getting paid for data, and I lost that comment. I would love, quite frankly, and you know how I am on this, so I won't get on my soapbox, but the reality of it is it's the patient's data. And we used to curate that as doctors in a paper chart. It wasn't our record, it was the patient's record, and we were the curators of it, right, or the custodians of it. In the world of electronic data, now the data has shared rights. It belongs to the patient, but there are shared rights with the data repositories, et cetera. The only people who don't get paid for their data are the patients. Everybody else ends up using data for different purposes. And I have I'm probably a data communist in that regard. I believe that every provider ought to have the relevant data they need to provide the best care for the patient, and we all ought to compete on the services that we provide and how we deliver that care, not compete to try and get data. Anyway, I'll get off that soapbox. I know that's not where you wanted me to go.
I think, well, a couple points I wanted to kind of circle back to. The piece related to data actually had to do with payers reimbursing the provider for reviewing the data. That is what was kind of in the chat there. It was an interesting concept. I had not heard that. Going back to the overflow of information, and I'll relate it to what happened in email, right? So as we saw email, and I don't think anybody would say I can live without email today, or I can live without text messaging. They probably wouldn't say that, but I think everybody is burdened with too much information coming through those channels. And so we've seen technology, like in my Outlook, I use Outlook for email. It has like focused, and it's gotten smart enough that it knows what I want to see, and then what kind of filters out everything else that I can peruse on my own time. To your point, Dr. Schoch, as this is where the partnership with Office Practicum becomes really valuable to the provider community, is that Kno2 is going to be that conduit for the data, giving access to it at scale. And then between ourselves and that partnership with OP is driving what's meaningful to the top for the providers to be able to see it and review it. Knowing that technologies like AI are accelerating that and making it valuable to the end user, because we really can't be without the data, and we're in this phased approach to solving this interoperability problem. So we talk about the next generation of interoperability. This becomes that's the accelerant even further for the adoption of it as we get more and more provider feedback, what's valuable, what's not. It becomes really important. We got to adopt it first and then start really working into scrubbing, I'd say sanding the rough edges and really getting it something to a usable state.
Yeah, and I think I agree with you, and I think you said something there I want to emphasize, that there is so much to talk about in interoperability, but all of it's useless if we're not first connected. You've got to get connected, and don't be somebody else's awareness problem, right? So be connected, so when they connect, they can actually connect to you and share with you, and vice versa. I think getting connected is absolutely critical. Something else that struck me when you were saying that, Therasa, and this flow of information is just thinking about pushing and pulling information across the network. There is a real advantage to being able to query a network for information that you find relevant when you find it relevant, right? So I've got a new patient that comes to my office, and I can query based upon that new patient and get information based upon that new patient when I'm thinking about it, when it's relevant to me, et cetera, which also helps contextualize the value of interoperability differently, rather than just always thinking about I'm getting information pushed to me, et cetera. There are times when I'm actually pulling information based upon my need for information, which is a very helpful context.
Okay, we've taken a lot of time just talking.
No, I think this is exactly the direction we want to go. I really appreciate that. You know, what I hear is, and we see this a lot across healthcare tech, pain of same versus pain of change. There is going to be a time frame there where you're going to maybe go through a little bit of the pain of change before you get to the green pastures, as you put it, Dr. Schoch. And you know, I think that there's sometimes no two ways to get around it other than maybe putting together at the practice level when can we do this, what would be the best way to go about doing this, and what would be some ways to mitigate that pain through the process. I think that the pace of change in healthcare is, and proactively adopting new tech, we all know that it's a challenge. It can be really, really daunting for small practices, especially. I'm wondering if you could go ahead, Dr. Schoch or Therasa, whoever feels comfortable jumping into this. We're going to move on to a slide where it talks about the different personas that are impacted by interoperability.
Yeah, and I'm happy to lead out there. And Therasa, please add the color that you feel appropriate, or anything that I miss in this regard. And I think we've touched on a lot of this. I think for me, and I said this earlier, for me, it's not a technical conversation. To me, this is a business conversation because interoperability, the flow of information at the point of care, has significant impact on the P&L, meaning the business fundamentals of my healthcare practice, of my hospital, of my whatever it is, but of my healthcare practice, meaning I can actually save in my expenses. I can be more productive with the FTEs I have when I am interoperable and information is freely flowing. Number two, the provider, we've talked about this and touched on this, the provider experience of care. The ability, and take the question that was just raised that we attempted to answer around the volume of data coming through. That's a challenge. And I don't know as anybody's completely cracked that nut, but there are ways that we're working to crack that nut. I think query-based workflows, meaning querying for information when I want it, it doesn't necessarily change the volume of information I would get, but it makes it more relevant to me, and I'm more likely to sort through the information I need at a time when I think that information is relevant. So those query-based workflows are really important in my mind. But the provider experience of care, reducing administrative burden by providing information for them in advance that's relevant to their situation, that's relevant to the decisions they need to make, increases the speed with which they can make complex medical decisions, increases the clinical accuracy of their clinical decisions for patients, and shortens the time from diagnosis to treatment in many cases. That all helps a provider deliver better care, improves their provider experience as well, decreasing the administrative burden specifically. The patient, we've talked about it in a couple different ways. There's a real important understanding around improving care coordination, meaning care received from one provider to the next provider around the same illness, where information needs to be shared between the two to pick up where the other left off and move forward, whether it's referrals, whether it's from a provider to physical therapist or an ancillary provider. Care management is incredibly important for those with complex clinical diseases and cases. And then I just think the patient experience. There is nothing better than, as a patient, being known by your provider, meaning that the provider has information about you, that they're confirming and asking about while they're building rapport, as opposed to you having to list off a bunch of things that you've listed off 5 times before in that month when you've seen other providers, that we could easily communicate between providers, and you know that patient when they see you. And the last one, and I talk about this all the time, and everybody says, well, what does it matter to pediatrics? I talk about the health system as a whole. We all know that there are only 3 personas that pay for healthcare in this country. One is Uncle Sam, meaning the government, but they do so through taxpayer dollars, which is us. The second group is your employer, who pays the lion's share of the premiums for anybody's health insurance plan if they get it through their employer. And the third one is you, the patient, or us, when we go and provide those services, either through a deductible, a copay, or out-of-pocket expenses. Those are the only groups of people that pay for healthcare in the country. Payers just move money from one place to the next. There is a real opportunity to lower the cost of healthcare by having the right information in the right place at the right time. I give examples about this all the time, from a standpoint of somebody comes with abdominal pain after being seen in the emergency room over the weekend. They see me on a Tuesday. Their abdominal pain is the same, no worse. If I have the CT scan results from the emergency room readily available to me so that I can review them in the light of my physical examination and the interim history, I am much more likely to not order another CT scan, but move to the next level of treatment or evaluation for that patient, and therefore save money out of pocket for that patient, save money out of pocket for the healthcare system as a whole. I think of safe care environments and how it improves the healthcare system. I think every provider on the call today would be hard pressed to explain to me cogently how an accurate medication list and an accurate allergy list isn't paramount for a safe care environment. And if you don't have those things, I can tell you that the care we're delivering is not in the safest possible environment that we can have. Interoperability helps with that process as well. And then the cost and the complications related to medical errors associated with medications. And the list goes on and on and on. And it impacts individual providers have an ability through interoperability to impact the overall quality and waste in the healthcare system, whether you're a pediatrician, whether you're a geriatrician, through having information exchange at the point of care for treatment. So that's really what that means. I think we touched on a lot of those things, but that's how we start talking about the impact of interoperability. And it's really a business decision, not a technical decision. It has technical implications and technical need. But if we're talking about technology first, we're missing the point. And we're never going to get people to adopt interoperability. That's my soapbox, Theresa.
I don't think I can step up to it. It's so high. I mean, related to this whole conversation on the impact of interoperability, I always say imagine the future, because we talk about what interoperability is doing today to stop the bleeding, if you will, to stop the pain that we're uncovering and the things that we have to get our hands around. But interoperability is also very much of a future-facing technology, meaning it takes us into the future. Who knows where it takes us? And the ability, once data is moving and we have the ability to perform magic on data, then we can do whatever we need to. So we work closely with a group that I use them uniquely here because I think it has an interesting audience with the pediatric group. We have a virtual care platform partner that provides virtual care for eating disorders. And obviously in the pediatric population, that is, and again, I'm playing a physician, and Dr. Schoch always makes fun of me for doing that. But in the pediatric world, that's a very real thing that a pediatrician, if they see it, maybe in their growth charts, or they see it and it's showing up and it's manifesting itself, that you want to be able to get that help for that patient, for that pediatric patient and their family. So in this group, like for instance, with a group, it's called Equip Health, I'll use their name here, is they provide nationwide virtual care services for eating disorders, and they work very closely with the pediatrician. A fundamental part of that, though, is sharing the data, i.e. such as the growth chart and other data that's in the Office Practicum electronic health record, being able to share that electronically and send them a referral virtually, if you will, that came out of the OP system that says, hey, I have this patient, I don't have the means to support, I don't have that within my office to do that, but I want to stay very close to, it's my pediatric patient. Can you take care of this patient and keep me involved in the care? And let's share data back and forth on what's happening if you're virtually providing those services. That's an example of where interoperability can take the future and is taking the future to now coordinate care with these opportunities that you didn't have before. And you certainly didn't have the resource within your organization or maybe the expertise to manage an eating disorder, but now you do, and the ability to coordinate care virtually with this group. So I use it as an example to say, imagine the future. This is what we're doing today with stopping the bleeding, but the future is unlimited in terms of what we can do to transform our healthcare delivery system with interoperability.
And Therasa, boy, that is such a great example. And when I think about it, interoperability is allowing a virtual care provider in the niche specialty area of eating disorders to scale scarce resources, overcome barriers to care that are generally thought of as health inequities in some cases, or SDOH, to make that type of critical care available for so many more folks, and their bi-directional connectivity through interoperability with mainstream healthcare makes them part of mainstream healthcare, right? Because now they have access to the same information the mainstream doctors do, whether they see them in person or not, and vice versa, which is really an important piece as you talk through that. The last thing I would say is this is an aspirational statement and kind of an aspirational section of the conversation. But when I think about it, we are at a critical time in healthcare over the next 5 to 10 years. And this isn't the conversation around value-based care that's taken 25 years to get where we should have gotten in 5 or 10. This is a conversation around interoperability is the absolute necessary infrastructure in healthcare to drive and support the innovation necessary in our care models moving forward. And I think Therasa was alluding to that in the example that she gave. But it's a critical time. And it's not interoperability adopted by Office Practicum and sitting on the shelf at Office Practicum. It is interoperability adopted by and integrated into the Office Practicum software and used on a daily basis by the providers that have Office Practicum. That's what we call edge adoption. You hear us talk about adoption all the time. That's adoption. That is where the real magic is. We can build interoperability into technology all day, and if nobody uses it, it makes no difference. And the last thing I would say too is that look at this interoperability in the future like you look at Wi-Fi on a laptop. I don't know how many of you have purchased computers personally for your own use over the last half a decade or decade, but I bet you don't buy one without Wi-Fi or without Bluetooth capability. You wouldn't even conceive of it. You wouldn't even conceive of it because it would be a useless hard drive that you could do local work on and couldn't communicate with anybody else. So why would you have your EHR that's not connected in the same way to other EHRs through the interoperability feature set? And we talk about the data and the massive data. The internet is this massive source of data that you have access to through your internet browser and your Wi-Fi, but you go out there and you search for what you need. So there are ways that we can get you what you need from a query perspective as well, but you've got to use you've got to turn on the feature. You've got to have the feature enabled, and you got to be willing to, as you said, go through the pain of change to get to the promise afterwards. So again, I'm not going to get off my soapbox. It seems like I still am on it.
We love it. We love everything we have to say. Thank you so much. You know, it's really interesting to talk about the impact of interoperability alongside the pain points of practices everywhere, the nuances at pediatric practices. I think it's all very important, pain of change versus pain the same. I'd like to pivot just a little bit and move on to our next slide about QHINs, Qualified Health Information Network. I'd love for you guys to spend a few minutes. What is a QHIN and how can it help our pediatric practices?
Absolutely. And if you just go Google QHIN, and you're going to see a ton of information right now coming out from the federal government. I'm also going to relate it to, there was a really interesting statement made in chat regarding crowdsourcing. So this is going to come back full circle to that. So related to QHIN, so what is QHIN? QHIN is, what it stands for is Qualified Health Information Network. And starting in roughly 2020, the federal government became very serious about major issues that they were facing into in healthcare. Not that they haven't been for some time, but they're now putting a bunch of movement behind it and saying, hey, we've got this aging population, obviously not related here. I've got a provider shortage that I'm facing into. I've got healthcare costs that are accelerating beyond what I can manage. How am I going to start addressing this immediately? And one of the fundamental ways was with health information exchange networks nationwide. And we've had some other attempts at this. Obviously, we have direct secure messaging and Care Quality Commonwealth. Those are names that you'll hear. You see one on the screen. Absolutely very effective networks, and you have access to those through the OP Kno2 relationship. But QHIN kind of took the best of all of those networks, and through a new framework called TEFCA, the Trusted Exchange Framework, and it's really a trust between vendors. They came forward with this criteria that says we're going to identify national networks, healthcare organizations that will become our national network. So if you think about them like the AT&Ts and the Verizons of the mobile industry, the cellular industry, that is what QHIN is for healthcare information exchange at a national level. So all that said is in 2022, Kno2, along with some other organizations, actually kind of a long list, submitted an application to the federal government to become one of the selected, the anointed networks for the healthcare. Took a few months to get through it, but Kno2, along with 6 others, there's a total of 7 of us, were selected to become a qualified health information network. And in 2023, we were anointed to go live. So in February of 2024, we were anointed to go live along with the 6 others to start sharing information at scale nationwide. Included in that list of others is Epic, as an example, and Kno2, along with 5 other ones, that in a total of 7 that are qualified health information networks. Our now whole focus in life is to do exactly what we've talked about here, is take the last two decades of talking about interoperability, attempting interoperability, trying to really solve the problem, and take all of those learnings and bring them into QHIN. And based upon what we're seeing, it is the first time the federal government has come behind it and said, we're basically requiring, first of all of the federal government agencies, so Health and Human Services, CMS, Public Health, all of them have to become attached to a QHIN. That's the first time we've seen that at a national level. And the federal government is putting it into a bunch of requirements that are coming forward, because it's seen as the way that we have to save our healthcare system from everything that's imploding, if you will, not to be a doomsdayer here. So that's what QHIN is, and we get that. Kno2 is a QHIN. Obviously, in our relationship with Office Practicum, we're bringing QHIN to you. Now, what does that mean for you? Nothing. Meaning, if you sign up for interoperability with Office Practicum, you will become attached to a QHIN. And if we do our jobs right, which I'd like to think that we are, you don't have to think about, what do I need to be, part of a QHIN? What do I have to do? What do I have to do? You don't have to do anything. It's like going to the Apple store and getting your new phone, and how magically all of a sudden it's attached to a Verizon network or an AT&T network or a T-Mobile network. That's exactly what this is. And we're taking you to the next generation, to use Dr. Schoch's word, of health information exchange, now happening at a national level. And to show you the serious is the federal government's requiring it. So we know it's going to come forward. It's going to continue, whether we like that or not. The federal government's going to continue to push on it, saying it's going to become part of payment. It's going to become part of the carrot and stick approach that they've used in the past. And this time it's here to stay. It is a bipartisan initiative. It's been there for that long. It came out of the previous administration. It really took reality in this administration. So we know it's bipartisan, so it's going to continue to stay, and it's really fundamental to what's happening in healthcare. And Dr. Schoch, I don't know if you want to add anything there.
I can't add anything to that. That was fantastic. I think that's a really good description.
Or did I just completely just exhaust you with that, and that's why you.
No, you didn't exhaust me. I think I'll emphasize, because you're forcing me, I'll emphasize one point, and that is the point that I love the question. What does this mean to you? It shouldn't mean anything. Through the relationship with Office Practicum, you guys are going to get QHIN services, and it's going to be the network that you're exchanging and querying through in the future. That's all that means. But you guys don't need to concern yourselves with that. Get connected, and let's work on the workflows and all the other questions that you have around how do we make the workflows better, how do we filter the information, and so forth. But know that through Office Practicum, you guys are going to be connected to the next generation, and the next generation after that, and the next generation after that of communication through Kno2. So
yeah, there is a question in chat, if I have time, just to touch on that with the CrowdStrike, is that it's a very real concern. Do we have time to touch on that? Just want to be respectful.
Yeah, that's fine. That's fine.
Okay. So, and I would say both the CrowdStrike and right before CrowdStrike was the Change Healthcare debacle, right? So where we had Change Healthcare, which is kind of a clearinghouse for a lot of payments that go through, it very much impacted our provider community. That between the two, those draw real concerns for people, is when I have a single point of failure, if you will, that I'm shepherding all my information through. What do I do in those circumstances? And I'll draw that actually back to QHIN, because it's a very real issue. And I would say that issue is not going to go away. Once we bring everything to the internet, right, that issue doesn't go away. What is mitigated with QHIN is the way the QHIN technology works. We have 7 different networks where there's redundancy between those networks, right? It's not a single point of failure. Is it possible that Kno2 could go down? Absolutely. Is it possible another QHIN could go down? Absolutely. It is meant to intend to mitigate that circumstance where that traffic can be redirected to other points of opportunity through QHIN. So we are very real time looking at that. How do we continue to mitigate that challenge? So we don't bring that kind of influence back in. But at the end of the day, there's also always the old standby, right? We have fax as a backup to that. Kno2 includes faxing services. We don't want to see information be the daily habit of moving across the fax machine, but we are absolutely mitigating it, and it is top of the list for our security folks as part of QHIN.
Yeah, wonderful. Thank you, Therasa. I'm really glad that you touched on that and we're able to get to that question, as I know that's something that's on everyone's mind. And really just our next slide before we get to Q&A is really about, the key steps for being able to take advantage of the impact of interoperability. And I think that the first step is getting connected, right, Therasa? Like, get started with it through the partnership with Kno2. OP practices have access to integrated care quality. On that previous slide, we had a QR code there. I don't know if our audience had a chance to scan it. You will get this deck afterwards, but you'll be able to see and discover who in your area is connected. And then also, I'm not going to go into all of these services, but just want to make sure that everybody on this call understands that there is interoperability for OP pediatric practices. There are solutions available to them today. Is there anything that you'd like to add to that, Therasa?
I would say that these words may not mean a lot to you. Relate them to the workflow question we asked at the beginning. I think it was the second question, that all of your workflows, literally everyone that was listed and maybe some of the others, we didn't get to see them all, are addressed through this list. And it is about adopting, so contacting Office Practicum and saying, I need to get connected and to start addressing the workflows and referrals. I think were top of the list, if I recall correctly, through that. The first 3, I would say, you're directly impacting those workflows to go electronic. So related to the workflows that matters to the providers, everything's addressed in the list that you see here.
Okay, awesome. Thank you very much for that. And so we are going to move on. We only have a couple minutes left, but we do have time for a few questions. If anybody has some additional questions they want to add, go ahead and fill it out in the questions box on the Go-To module.
I do want to draw attention while people are doing that. I think you had said it, but that QR code, if we go back to, I think it was the third polling question, the third polling question, the #1 issue was awareness, right? And I don't know who has what. And that QR code is intended to help with the awareness problem. And it will take you literally in your zip code region or wherever your clinic or clinics may sit. It'll tell you the capabilities of the other providers in that area. So are they on direct messaging? Are they on care quality? Are they? And you can start getting that analysis, if you will, for your zip code area. Because I always say interoperabilities or connectivity happens nationally, interoperability happens locally, because I need to know care coordination happens locally. Tell me who's available. And that QR code, can't emphasize it enough. Free little survey thing it'll provide you, and it will tell you who in your area that you maybe coordinate care with most that's connected on the networks today.
Yeah, and generally recommending that you look at that and see the practices or the names that you frequently do business with, and don't bite it all off at once, but go to those folks that make up a good number of your referrals or those types of things, and start talking to them and get them, make them aware that you're now connected, and can we do things differently.
That's awesome. Thank you so much for mentioning that. I entered my zip code when that first came out. It was pretty cool. What's also really cool is if you enter, you fill out a form, you're going to get an email back with information, but it's also going to have a really neat video that Kno2 put together on talking through how you can use this information immediately. So I think you'll find it all really helpful. We have a couple of minutes left. I want to ask one final question. We've got people who are really busy in their office, and we know this is just the way times are. If there was just one thing they could implement now to help with information exchange or workflows to have the greatest impact, what would you say that would be? And you can have different opinions.
Yeah, we might. And his probably matters more than mine is. I'd say care quality. I would implement that now. I think most of the OP providers have direct messaging, and we're doing a lot of work nationally for that. Care quality gives information at your time and when you want it, to what Dr. Schoch was saying earlier, is the ability to query. Patient shows up at your office, patient's coming in, get care quality enabled and get training for your staff on how to use it within OP.
Wonderful.
Yeah, that's my answer as well. The ability, I called it the query function earlier, care quality, TEFCA, or QHIN in the future, but the ability to reach out to get information when I want it and when I'm thinking about it and when I think it's relevant. That to me is probably the greatest way to become a quick adopter of interoperability, because you immediately see the value of it, because you've determined you need it. And when that information comes in and you're able to look through it, you begin to see how important it is, and then you can begin to apply it to other workflows. Yeah, so I think that query function, turn on your care quality connection through OP.
Awesome. Thank you. We are at time. Therasa, Dr. Schoch, thank you so much for sharing your insights and perspectives with us today. For our audience, thank you for joining us today. Please take a moment, if you would, to fill out the survey at the end of this webinar. Let us know if it was helpful to you. And we're going to be sharing the webinar, the deck, some additional resources, so look for that in your email. And we look forward to seeing you at our next event. Enjoy the rest of your day.
Thank you.
Thank you so much.
Bye-bye.
Bye-bye.